So this will be the last clinical and care governance meeting before the recess. So I'll try and remember to wish you all a good recess when that comes along. Right, can we have apologies first? I've already got apologies from Francis Dodd and Andrew Murray. Is there anyone else?
That's all the apologies intimated to me, Councillor Hannah.
Okay, thank you. Do we have any declarations of interest? Then we will move on to the minutes of the meeting of the 15th of March 2024, which is in your papers. Do people accept these as a correct minute? Take yes. And are there any matters arising that are not otherwise on the agenda? No? Okay. We'll move on then to the next item, which is the action log. And there's only one open action on the action log, which is the update on suicide and drug-related death prevention. There's some detail included in the oversight report, and there will be a further report in September. So is there any comment or question on the action log? Okay, thank you. So we'll move on then to the oversight arrangements, which I think Suzanne is going to lead on.
Thank you, Chair, and good morning, colleagues. The report provides a summary overview of local oversight and assurance arrangements that are in place relevant to the Health and Social Care Partnership. It's intended to provide assurance to the committee members of these arrangements. So at section 4, we've provided an update on Falkirk Public Protection Chief Officers Group's most recent meeting held on the 13th of March this year. And at that meeting, they considered their COG annual risk register. They noted some key changes from last year's position and agreed to support a number of directions, and that's set out in the report. At section 5, we provided an overview of NHS Forth Valley Clinical Governance Committee meeting, and that was held on the 12th of March this year. Table 1 of the report details the reports, updates and presentations and discussions which give assurance about safe, effective, person-centred care. Similarly, the agenda for the Clinical Governance Working Group meeting held on the 11th of April is set out at Table 2 and details the reports and updates that were considered at the meeting. The Health and Social Care Partnership and NHS Forth Valley continue to work with care homes and care home staff to support and assure infection prevention and control measures, support outbreak management, and to ensure that fundamental care needs of residents are being met. And the Care Home Assurance section of the report provides an update of the work since the last update. Just to note, the number of reviews completed by chart from February to April this year was 102, with 156 outstanding reviews. Just to contextualise that, the total number of placements funded by Falkirk Council, both in and out of area, in April 2024 was 901 placements. The chart team themselves have a number of adults allocated to them at 690 people, which accounts for about 77% of all placements, with the remainder being allocated to locality and specialist teams. At section 7, we've provided an update about the Adult Protection Committee, and this includes an update on the Facilitated Practitioner Forum where they held recently that considered the Mental Welfare Commission publication of an investigation into the care and treatment of Mr. E, where they concluded that the Mental Welfare Commission, concluded that he had been failed by systems and structures put in place to protect him. So participation at the Practitioner Forum focused on the investigation report, and it was good attendance. The attendees valued the opportunity to look at the case and to discuss this across the partnership. And in addition, single agency self-evaluation has taken place, and management teams in both health and community care teams have spent time examining key areas of reporting relevant to them. We've concluded an update around the Alcohol and Drug Partnership at section 8, noting that the newly ADP executive continues to meet and draws on a range of senior representation across council and partners. The There are a number of subgroups now being developed, and that includes a third sector managers group being facilitated by CVS Falkirk to ensure services have proper representation and can meaningfully contribute to strategic development. The ADP continues to make positive progress in implementing the MAT standards, and there's been demonstrable year-on-year improvement, which we've noted in the report. And we've also, as you've noted in the action law, we'll be bringing forward a further, more detailed report to the IGIB in September around this area of work. An update on the Health and Social Care Partnership Clinical and Care Governance Management Group is provided as a separate agenda item. And finally, the Health and Safety Management Group meeting on the 23rd of April this year is set out in section 10 of the report. So in conclusion, the report provides a summary of the relevant oversight arrangements and meetings for the Clinical Care Governance Committee, and members are asked to consider and comment on the contents of the report as set out in the recommendation at 2.1. And I'm happy with colleagues today who are participants in many of these groups to take any questions. Thank you.
Thank you very much, Suzanne. Thank you for this very good oversight report. It gives us an overview of what's going on. Could I just ask you to clarify a couple of things? You make reference to CHART. Could you just clarify what CHART stands for?
Yes, it's the Care Homes Assessment and Review Team. I'm looking to Caroline to confirm that if I've got the acronym correct.
It's the Care Home Assurance and Review Team.
Thank you very much. And you also referred to the ADP hosting a CREATE event in May. I wonder if you could explain that, please. What CREATE is?
Oh, Martin, can you clarify? Sorry.
Sorry, what
Should we
was, I couldn't make out what was being said there.
Falkirk ADP hosted a CREATE event in May. I'm just wondering what CREATE stands for. Sorry, it's my pet hate is acronyms.
Yeah, and I'm sorry, I have absolutely no idea what
David
that
has
means.
his hand up, so I wonder if David knows the answer to that one.
Sorry, yeah. CREATE are the afternoon education sessions that we deliver to everyone that works within general practice. 4 times a year we have these sessions. So one of this particular session was on delivery of the MAT standards.
Excellent. Thank you very much, David. Okay, does anyone have any other questions or comments? No, in that case, we have considered and commented on the contents of the report. So thank you very much. We move on now to the next item on the agenda, which is the inspection reports. And I understand, Caroline, you're going to bring that forward.
Thanks, Chair. So I was just going to talk through, this report is a summary of the inspection activity that's happened for our register services since the last meeting in March. So in terms of the inspections, we had 4 inspections that took place. The first one that we've highlighted in the report is the housing support service for the West locality. That's a service that's provided for people living in their own homes in the West area of Falkirk. The service is provided for people with a wide range of care and support needs, including older people, adults with physical disabilities, people with enduring mental health problems, and people living with dementia. Services are provided in both a short-term and long-term basis. Then all inspections were unannounced, and that includes this inspection. The findings of this inspection was very good for people that experience compassion, dignity and respect. People get the most out of their life, and people's health and wellbeing benefits from their care and support. It was very good for leadership around quality assurance and improvement is led well. And in terms of how well is our care and support planned, that again was rated very good. And the particulars of that are around assessment and personal planning, which reflects well people's outcomes and wishes. Similarly, the central locality, which is the same service as what's provided in the West, but it's in a different geographical area. Again, the findings were, very good for all areas. And then just moving on to the east locality, again, it's the same service that's provided, but it's that other geographical area that's within east. And again, all areas that were inspected were rated very good. So that's how well do we support people's well-being, how good is our leadership, and how well is our care and support planned. The key messages from the 3 inspections reports noted that the services were very well managed and improvement focused on services. People who used the service were happy overall with the care and support they received. The Care Inspectorate found that staff working in the service were dedicated and committed to ensuring the best outcomes for people. Staffing pressures had some impacts at times on the level of continuity of staff. So just moving on to 4.9, the service that was inspected there was a mobile emergency care service, which provides housing support and care at home for people living in Falkirk and surrounding areas. After an assessment of their needs and eligibility to use the service, people have an alarm system installed in their home that connects to the MEX contact centre. Service can provide short-term visiting support for people coming home from hospital or people receiving palliative care, and the service aims to provide a prompt and appropriate response to emergency need. And this service is delivered across Falkirk HSCP. Again, the inspection was unannounced, and as a result of the inspection, the Care Inspectorate noted outstanding requirements from a complaints inspection had not been fully met and repeated relevant parts of the requirement in the report. The Inspectorate noted that some action had been taken to address the issues raised within the requirement, and were satisfied that with additional time we could meet that requirement. An area for improvement made on the 3rd of February 2023 had not been met and was due to be revisited, and I can give an update on the work that's been undertaken since that inspection. But just focusing on the outcome of this inspection, in terms of how good do we support people's well-being, for 1.1, people experience compassion, dignity and respect. That was graded good. For 1.2, people getting the most out of life. That was graded good. 1.3, people's health and wellbeing benefits from their care and support. That was graded adequate. How good is our leadership? And that's in reference to quality assurance and improvement as being well led. That was graded good. How good is our staff team? Staffing arrangements are right and staff work well together. That was graded adequate. And in terms of how well is our care and support planned, that was graded good. In terms of the Care Inspectorate key messages, it was noted that the service strived to meet people's needs as quickly as possible. Staff were kind, caring and respectful to people and were well trained in order to meet varied needs. The service gave people a high level of reassurance, and at busy times the service was challenged in attending to people quickly, and further work was needed to improve that. I'd like to add in, it's not within this report because we just got an update this week around how we were progressing. Following the inspection, we did an action plan that was required around the requirements, but also areas for improvement. And we had a timescale to meet the requirements by the 20th of May. In terms of the work undertaken from the inspection up until that time, we considered demand and staffing levels and increased support to a minimum of 4 staff per shift. We built up the management support team by putting in a full-time senior mobile operations coordinator. We updated and distributed the MEX leaflet, which provided up-to-date information about the service standards and what they could expect in terms of service standards. And we improved communication. For example, we changed the referral and review paperwork to include the option of the family member or next of kin being informed of any service users' alarms. We also implemented the text message service for family in case they wanted to be notified when an alarm is activated. So we were tightening up that communication and the support that we provided. We continued to progress work in terms of improvement. We provided updates in terms of inductions and staff training. We're looking at the introduction of people safe devices for staff lone working and reviewing the policy around lone working. We're identifying better ways to utilise staff with the possibility of an allocations app on their phone. And we're looking at focusing on collaboration with the other areas so we can look at the synergy between care at home as well as MEX. So following the inspection, we've continued to liaise with the Care Inspectorate, and on the 10th of June, the Care Inspectorate carried out a follow-up inspection, which focused on the two areas of requirement and also the area for improvement. And the initial feedback has been the service has responded proactively to the issues raised at previous inspections. The improvements that have been made with regards to staffing levels have been positive, and improvements have been recognised in terms of clarity around remit and response of the service, and care and support continue to be regarded to be provided at a good standard. We've had the draft inspection report, and it's just to highlight that currently as a draft, but that is indicating that we're going to get indicative grades of 4 for all areas, so that recognises the improvement work that we've undertaken. So just in terms of the summary, going back to the report that's been submitted, we provided a summary of all the relevant inspection reports which have been published since the Clinical Care Governance Committee meeting held in March 2024. And local Care Inspectorate Health Improvement Scotland and Mental Welfare Commission improvement plans are being monitored by the lead service managers and relevant managers of the HSCP senior leadership team. And I don't know if there's any questions around that.
Thank you. Sorry, was somebody trying to come in, or is it just a feedback? Just feedback, I think. And obviously, the next inspection is the one that is of some concern. But I think it's important, you didn't quite highlight the bit, which was that the Care Inspectorate noted that the staff were striving to do everything they could, and they were kind and caring and respectful. So the issues about the service are not about the staff. It's clearly about what the issues that you've been addressing, the staffing levels and the systems that are in place. So very pleased to hear that very quick action has been taken, and pleased to hear that the subsequent follow-up inspection has shown that there will be an improved position coming forward in the future. So thank you for that. I mean, given that the inspection was what's February, I think it's a credit to the leadership that you have taken that action within that timescale. So thank you for that. In terms of the housing support services, very pleased to see that they are very good all the way, and so it's a credit to both staff and the managers that that is the case, and I hope that you will take that back to the housing services and give them our thanks for their hard work. Anyone got any questions or comments? No, in that case we have considered and commented on the report. Thank you, Caroline. So we'll now move on to another one for yourself, Clinical and Care Governance Management Group.
Thank you, Chair. So I'm presenting this report on behalf of Nicola Wood, the Chief Nurse for the HSCP. So the purpose of the report is to provide Falkirk IGB Clinical Care Governance Committee with an update in relation to the ongoing developments to the Clinical Care Governance Management Group structure. And in point 3, it obviously identifies the background around how we've taken this forward and what the approach has been in terms of past activities. But if I can just move on to number 4, the current position and the proposed redesign. What we're proposing is 4 formal subgroups of the Clinical Care Governance Management Group are developed to support recorded and detailed clinical care governance discussions within the operational teams. The subgroups will be required to formally report into the Clinical Care Governance Management Group and provide reassurance to the management group as mentioned above in 3.2. So that would be about to understand past activities, introduce learning into present services, monitor progress with ongoing work plans for improvement, and outline what the risk mitigations are around that. The subgroups identified as key areas across the HSCP will be expanded to include partner agencies as the model develops. The current proposed groups are community-based services, and that includes nursing, EHB, mental health, learning disability and out of hours, bedded care, including community hospitals and internal care homes, locality services, including social work and adult support and protection work, and other regulated services. And we would put our kind of our care at home assurance review team within that, given the work that undertakes in terms of care home reviews. The subgroups will each receive reports from the services included and will explore relevant areas in detail. The subgroups will then provide reassurance to the Clinical Care Governance Management Group that key quality indicators have been assessed, evaluated, and potential problems or issues with care delivery have been identified, quality of improvement work is identified, and progress to overcome issues and learning is shared as appropriate with colleagues. The subgroup chairs will highlight specific areas of escalation to the Clinical Care Management Group chairs and members. We've looked at reporting templates which are based on the Vincent framework but also take cognizance of the Scottish Government guidance around clinical care governance. We're looking at 5 dimensions and associated questions around organisation and services that can be used to help understand the safety of their systems. The key dimensions which will be used for reporting are: is care safe today? That includes active governance and emergent issues. Was care safe in the past? That focuses on key metrics, safety measures, adverse events, audits, etc. Will care be safe in the future? That explores guidelines requiring renewal, identification of potential new harms and staff training. Is our care person centred? That includes compliments, complaints, staff wellbeing, etc. And are we learning and improving? That includes adverse events, quality improvement updates and shared learning. In 4.5, it's recognised that we'll have a deep dive into one area each Clinical Care Management Group, and that's to allow for further discussion and understanding of services across the wide membership of the group. An area for shared learning will be presented to each Clinical Care Governance Management Group to support whole system developments, and we will then take that and cascade it around local teams for further development. The model will support onward reporting to both the IGB Clinical Care Governance Committee and the NHS Clinical Care Governance Working Group. At present, primary care and prison health care report via other routes. However, this will remain under review as the development of the group progresses. The Clinical Care Governance Management Group will formally review the HSCP Clinical Care Governance Framework. This will ensure the framework reflects both the clinical care governance arrangements across Falkirk HSCP following the developments detailed above. So in conclusion, the committee in their role to provide reassurance to the IGB on the systems for delivery of safe, effective, person-centred care is asked to consider and comment on the ongoing review of the clinical care governance arrangements across the HSCP as set out in the report. And if you turn to Appendix 1, you'll see a kind of high-level proposed structure that outlines the relationship between the different governance groups, but also the proposed subcommittees. And I would welcome comments or feedback around it.
Thank you very much, Caroline. Pleased to see this review going on and the emphasis on being a constantly learning environment, organisation to look at constant improvement. I think, Gail, you would like to come in?
I think Linda might have had her hand up first.
Oh, I apologise, Linda.
Yeah, thank you, Chair. Just from a clinical governance point of view, I think it's a really excellent group, and I think it's a really good way forward. And it ties in very closely with the way that clinical governance is managed in healthcare. So that standardisation and that approach is really excellent, so that we can have the same conversations and using the same currency when we're discussing safe care. So it's just to endorse what Caroline's proposed.
Thank you very much, Linda. Right, now come to Gail and then Margot.
Yeah, thanks, Chair. So just following on from Linda, this has been a significant piece of work that a number of officers have been progressing under the Chief Nurse's leadership, and it does really help to strengthen the assurance processes we have around clinical and care governance at an operational level, and it will be helpful to the committee in terms of providing that assurance that we do have appropriate clinical and care governance processes throughout the organisation as well. So it's obviously a work in progress. There's been a huge amount of work that's gone into it to date. There's still a journey that it's on, but it is an essential part of our ongoing improvement activity in the partnership.
Okay, thank you very much. And Margot?
Just in no way being critical of what's given, but it sort of appears to be not the whole story in some ways, because from a patient perspective, delayed discharge and staff absence seems to be complicating the completion of a response in the template for the Vincent framework. I'm not putting this very well, but I just wonder if current figures are affecting in any way what findings you have on the committee.
I'm not sure. Caroline, do you want to pick that up, or does someone else? Gail, would you like to pick that one up?
Yeah, so just really, so obviously the performance around delayed discharges is a key focus for our partnership and our wider system working. So delayed discharge performance obviously doesn't allow for the best outcomes for people coming out of hospital. It is a whole system challenge, and we're very much working as a whole system collaborative leadership group, so including the NHS, the Director of Acute Hospital, obviously the partnership, and also the council. Every part of that system has a role to play to ensure that people receive the right care at the right time and don't stay in hospital, the acute hospital, any longer than they absolutely need to in terms of delivering the care. So I think that in terms of the work of the Clinical and Care Governance Management Group, the key safety perspectives that are being looked at under the Vincent framework will help to make sure that we're aware of the associated risks, and we're have the right data in order to inform our decision making around the best possible actions in relation to that. So while delayed discharges doesn't explicitly feature within the Clinical and Care Governance Management Group Vincent framework, it is absolutely a key thing that we're continually focused on within the partnership to ensure that we can improve the performance in that area.
Okay, thank you, Gail. I think obviously from a patient point of view, that is one of the key issues. Is the fact that people want to get home as quickly as possible. And I'm hopeful that taking the whole system approach, and with the new leadership both within the Health and Social Care Partnership and the NHS, that we can begin to look at with new eyes. Not to say that the previous leadership was in any way culpable, but to say that perhaps just a new approach and a new review will help with that situation. We all live in hope. Any other comments or questions? In that case, we have indeed considered and commented on the update. And thank you for this, and we look forward to future improvements as well. Okay, we move on to agenda item 8, which is the Health and Social Care Partnership Complaints and Feedback Performance Report. Really snappy title. And I think we have Gordon McKenzie and Ailey Gallagher both to lead on this. I don't know who's going to start.
I'll start first, Chair, if that's okay with you, Ailey. Assuming that's okay. So thank you, Chair. In respect of the social work adult services part of the complaints performance, you'll have noted that there was a disappointing drop, particularly in relation to the stage 1 complaints. Looking at 4.2. The stage 1 performance declined from 83% to 58%, which is, as I said, is disappointing. Hitherto this year, complaints performance was around about 80% overall, it caused a certain amount of frustration and concern. We've responded to that by looking at where the complaints responses were not at the level that they should be, identified that potentially due to interim arrangements around the team managers in a number of teams, we think that's contributed to that dip in performance. We do provide support, obviously, to managers and to staff when there are vacant team manager posts for whatever reason. Those posts are vacant, but it stretches the staff group a bit more thinly, and I think that has contributed to that dip in performance this time round. Looking at table 1, you can see that there were 19 complaints in the last quarter, 11 of which were responded to in timescale. We would have expected that figure to be up nearer 17. So there's 5 or probably 6 complaints that we should have responded to in timescale that we didn't get to. So we met with team managers, had a discussion about that, re-emphasised the need to keep on top of responding to collates and timescale, reminded people of the extensions that can be applied for in circumstances which are appropriate, people being off or people being uncontactable or whatever, and we will continue to monitor that through the current quarter, and I expect to see an improvement in that. Stage 2 performance, the numbers are very small and they do tend to yo-yo up and down. That's largely to do with the complexity of those complaints, so I'm less concerned about that. That's a sort of pattern we've seen over quite a long period of time, but the drop in stage 1 complaints, although we have seen that, we saw that previously about a year and a half ago, it does appear that every year to 18 months there's a drop off in performance. So it's important that we keep on top of that and we keep supporting the staff that are dealing with those complaints to ensure that the complaints are dealt with in a timely manner. Table 2 that looks at the complaints over the past year, and that's where I'm saying that, you know, had we responded in the way that we hoped to, we would probably have brought our complaints up around about 80%, which is the kind of level that I've been looking to drive this forward to over the last few years. But you know, we will reinvigorate our attempts to do that and get it above 80% on an annual basis going forward. There is a missing detail on stage 2 complaints. That column, April to March 24, should reach 73%. So the performance there at 73% is okay. Obviously, want to improve that as well in the year ahead. Moving down the report, in table 3 gives a breakdown of where the complaints are coming, the type of complaints that we're getting. We are going through that with team managers as part of our monthly team manager meetings, where we're getting together to look at where the complaints are coming through and what we can learn from them across the service. Some complaints will be specific to, you know, individual teams, but others have a sort of cross-service. You know, there's stuff to be learned across the service, so we're doing that more formally now. That's a standing agenda item for the team managers meeting. But that the tables 3 and table 4 give you an idea of where the complaints are coming from and what those relate to. We had one complaint which should have been reported in the previous quarter that went to the Care Inspectorate. That's detailed in 411. The complaint and the response straddled the 2 periods. Complaints should probably have been reported in Q3 as opposed to Q4, so apologies for that. I'll skip over the NHS Forth Valley part of it just now and then go down to care opinion. As you can see at section 5, there's some information there about compliments and feedback that we're getting. There's one there from the East locality, and further down 5.3 there's details from the care opinion service. I have to say I am aware that we're getting more compliments than that, so I'm going to need to speak to staff and get them to steer things through care opinion so you get a better picture, because there are quite a number of positive, greater number of positive feedback messages that I'm hearing from teams. So we'll look to improve the what's captured there going forward. And I'll pass over to Aileen, please.
Thank you. Does anybody have any questions before I formally come in? Is that everybody happy for me to continue?
I think that would be useful if we dealt with any questions or comments on Gordon's set before we move on. I just want to say, I mean, obviously the deterioration in the speed of dealing with complaints is a matter of concern. What's also a bit of a matter of concern is you're saying that over a year, every year, 18 months, this happens. Have we got any way of kind of trying to identify what causes the trend and trying to resolve it?
I wouldn't say that I particularly got a way of identifying it. I'm basing it on the interactions that I have with staff, with the team managers, and my observations on it, Chair. I think that it is something that when the services are particularly busy, when it feels staff or when team managers reporting things are particularly busy, we have seen a drop off in the complaints response. So that's certainly part of the feedback that I'm getting, and I'm tying it in with the fact that in the first quarter, in the last quarter of 23-24. We did have an unusually high number of absences in the team manager grouping. We've appointed, people are back from sickness, we've appointed people where the posts are vacant. So we're in a different place now, and I would be hopeful that we would see an improvement that way. In terms of going forward, how we try and make sure this doesn't happen again, as I was saying there, we've now put it on to the team managers meeting as an agenda item. So on a monthly basis, we will be talking to them about this, or I should say at least a monthly basis, we'll be talking to them about this. We've also wanted to engage them in the positive aspects of this and the learning, so that people are not viewing it as this is another just a challenge. We learn a lot from complaints. It's important that we recognise that and take a positive approach to them as well. So it's partly about changing the culture about that. My view is it's partly about changing the culture about that, but also, supporting staff who are dealing with a lot, and sometimes complaints can be bumped down the priorities for understandable reasons, but we've got to keep it up there.
I think that is an important point that you make there, Gordon. It's no service is ever going to be in a situation of not getting any complaints. There will always be some complaints, and number one, when there are complaints, is to address the concerns that the individual has. But number two, and most important in many respects, is to learn from them and learn how to improve the service. So thank you for raising that bit. The other bit I wanted to comment on was the compliments, and I think it is important because as a committee and in so many of our reports, we focus on the downside because those are the things we know we need to do something about. but it's equally important from a staff point of view to be able to identify the good work that goes on, which is the majority of the cases that we're dealing with. Not we focus very often on the minority where things have gone wrong. So I would like to see more of the compliments coming in. Sorry, Stephen, you've got your hand up at that point as well.
Thanks, Chair. Yeah, just I should probably know this, but it just struck me in, I suppose, both complaint systems that we review here. When you go on to make a complaint, do we have like a common question answer section in that might? So a lot of complaints may be somebody kind of misunderstanding circumstances or what's going on. So a sort of brief common question answers might reduce the number or might reduce the volume in that space, might allow us to concentrate on the ones that we probably need to concentrate on. I don't know if we've got that or if we can consider a system like that.
So in relation to social work adult services complaints, they come through a system called Customer First, Stephen, which is set up for anything and everything in the council. So bins not being picked up properly, housing complaints. There isn't a kind of common bit at the start, at the front, that says that deals with that. The social work complaints do tend to be a bit more complex than many other complaints, but we do try and get managers into thinking of making have an initial discussion with the individual to understand what their complaint is about, and try and resolve it as early as possible. And there is you can divert things that way, and for them not to become a formal complaint, or not necessarily to go through the full complaints process, I should say. So we do try and divert in that way, but the existing system doesn't offer that at the front door, so to speak. That's when people contact us.
I've got Ailey and then Margot. But before I go on to Ailey, I just want to say, I use the Customer First system as a counsellor on a regular basis as well. And I think that in terms of the responses, very often it is the case that it's information, it may not be that there's been any mistake made. Sometimes it is just about misunderstandings about the process. So, and officers of the council get that opportunity to respond in that way. Ailey and then Margot.
Thanks, Chair. Stephen, just from the NHS's stance on the proactive complaint avoidance front, if you will, we have recently made changes to our complaints handling part of the website, in which you have FAQs that come up above the complaints form. There's not per se anything that's massively specific for Falkirk, but it is things like waiting times that signpost you to NHS Inform, where you'll see anything that's online within NHS Inform is captured there. It's the car parking complaints that we get, and just that sort of generalised stuff where we can proactively provide some information. So we do that wherever we're pulling some common themes that we can hopefully support people with proactive information that can be generalised even. As I said, there's not anything massively specific for Falkirk, but we do look for every opportunity that we could do it.
Okay, thank you, Ailey and Margot.
Just to say, I'm very impressed by the sort of analysis of the individual complaints and the fullness of your responses. Does the time of delaying a response affect this? If people have to wait, does their complaint sort of intensify?
I think Margot, in terms of what we would experience with people, I think they would be, there's a level of frustration if we're not getting back to them, and that's why I say we even if we don't complete the complaint response, because it's complicated, or somebody's off for a couple of days sick or whatever. The timescales are quite short for stage 1. I do encourage people to make that early contact so that people know that the complaint has been received and they have had that initial acknowledgement. And I suspect a lot of other people will not be happy, and it would increase the level of my anger or frustration if I didn't hear from anybody at all within that period. So you're right, complaints not being responded to in time can add to the depth of feeling of dissatisfaction, but I think that can be avoided even where there is a delay by getting in touch with them early so that they know that you're on the case. And most complaints that I've dealt with, and where there have been a need for an extension, people appreciate you getting in contact and acknowledging that you've got the complaint and that initial discussion and being listened to. So that goes a long way to allaying those frustrations.
That's right. I should maybe also have said that I'm aware that our customer first complaints and comments process is under review at the moment. There is some work going on to improve it, and these ideas can be fed into that process, because it's not as good as it could be, and we need to constantly improve that. Sorry, we've kept you waiting, Ailey, to do your bit, so I think we'll move on now. If you could present your section of this report.
No problem at all. Thank you, Chair. So in relation to the NHS complaints received, you'll see in section 4.13, the January to March performance was 46.2%. It's obviously not where we would like it to be. It is a slight improvement on the year-end position, which was 42.3%. We continue to have significant pressures across our teams. I've been here for about 6 months now, and I think in that duration of time, I don't think we've had a full team, just due to various absences. So there's lots of complexities going on from that perspective that we continue to try and work on and improve. I do anticipate having a full team by the end of next week. Long may it last, but that will put us in a position that we can change the way that we work. So one of the things that we will implement at that point is that each different directorate or HSCP will have a named complaints handler. So rather than all complaints going into a general pot, which is the position at the minute, you will have a named complaints or a patient relation, should I say, manager for Falkirk, as well all of the other directorates and HSCPs. That should mean that we start to pick out positions much more quickly of, have we got areas where responses aren't coming back to us on time, or are the delays in responses purely down to the capacity issues that we are experiencing centrally within patient relations. So more details will come out directly to those involved in the complaints handling procedure over the next week or so, while we finalise who that specific individual will be. But we're hoping that that actually makes a really significant difference for the teams out in Falkirk in the sort of smaller areas that fall foul to the very big industrial machine that is trying to get complaints out on time. Of the complaints received by the HSCP, none of the complaints were upheld, and I think there may actually be an error in the report in section 4.19, which reads that there were 5 complaints fully upheld. I think that should actually say 5 complaints that have not yet been resolved at the time of writing. The total was 4 complaints, both across stage 1 and stage 2, that were not upheld throughout that period. It's not to say that we don't have learning to take from each of the complaints that we receive. As Gordon says, these are all important, whether they are upheld or not. So the themes that we saw coming through related to communication and staff attitude and behaviour in particular, that's themes that we see across all of our areas across NHS Forth Valley. And we have got a programme called First Impressions Training. So it is what it says on the tin. It's about teaching people how to try and de-escalate concerns locally and the importance of that first impression, how we're communicating to people. So we are scaling up our ability to roll that out. It's been in place for a long time, but we're now training more people to deliver that. So we're just going through a programme of first and foremost picking out the kind of high prevalence areas where those complaints are predominant, but that will be offered out to the entire organisation and to any new starts as well. They'll be offered access to that training course as a default. We will then support that once that training has been completed with targeted simulation centre training. So again, there will be a process of rollout for that. It's likely to take a little bit of time to reach Falkirk formally as we go through some of the kind of hotspot areas that likely sit within the acute areas, but it will come. And if there's anybody specifically that people think need access to that, we'll support with those applications. Waiting times information is another theme that we see. Again, we have started to address that online proactively so that people are signposted to know how long the waiting time is in real time in accordance with NHS Inform. The other things that we see relate to falls documentation. We see issues with pressure damage. So a healthcare support worker academy has been designed and is in delivery. I think so far the organisation has possibly put through around 150 staff members. So that's people across all walks of life within the healthcare support worker workforce. And they're just resetting the absolute basics to make sure that everybody has the training and support that they need from us as an organisation in relation to what we document, how clear it is, where we document, the different pieces of paperwork that we absolutely have to complete and why, and obviously your skincare and your safer mobility training. So that's going through, and again, that will be accessible for healthcare support workers across the entire organisation, so Falkirk will be included in that. We are looking at how we make the final decision on upheld versus not upheld status. We are out of kilter with the rest of the NHS Scotland boards, and again that's across the organisation as a whole. So you may start to see some variance actually in what we report now. I think there's been a historic assumption that if the complaint relates to an organisational or a corporate type function, or there's nothing that a team locally could do to resolve it, that it's not upheld. But actually we're challenging that position that if we found something that as an organisation we could have done better, actually that should be upheld. So you'll see a slight change, I think, in the language and decision making process that we are using that may mean you start to see more complaints upheld. I don't think that is necessarily a bad position, simply just a more reflective position. So we'll see how the reports go over the rest of this year and if that starts to make an impact. But in a proactive explanatory mechanism, that will be why you're seeing that. I think the last thing that I'd sort of had noted down in terms of the report was that we will look to change how we report the themes in a similar way that Gordon does, that you've got the upheld status beside the themes so that we know actually what's the severity of the same themes that we're seeing, and where have we found that has been reflective or not reflective of what happened in real life. You'll start to see that in our reports as well, so hopefully that just gives us more information to learn from in due course. I don't think I've got anything else to add in relation to care opinion other really than what Gordon's already said. The teams have all got access and we do see stories coming through. They are shared with the teams who are specifically mentioned, and of the stories received in care opinion, they have all been positive as well, which is really nice to see.
Okay, thank you, Airy. A bit of a common theme here about staffing levels. So I think we're pleased to hear that you're going to be up to full staffing very soon, because that clearly makes it much easier to deal with complaints in a proper manner, or perhaps to avoid them in the first place. Anyone else got any comments or questions? We look forward to seeing the changes that you're talking about being brought in. And I do think we have to be very, very clear about the fact that complaints being upheld is not necessarily a bad thing. It is a question of the organisation learning from mistakes made, and that is important. Okay, in that case, we have considered and commented on the report. Thank you very much, Gordon and Ailey. We'll move on to item 9, Healthcare Acquired Infection Performance Report, and that will be Jonathan.
Yes. Thank you, Chair. Morning, everyone. So this is the performance report, the quarterly report for January to March of this year. I'll just highlight some of the relevant points, just so I don't go into too much detail. For care homes, support continues. We have an audit schedule that we visit all care homes across Forth Valley on a standing 3-month basis, depending on the support that's needed. So some care homes requiring monthly or even weekly support. So far for this quarter, nothing to highlight in terms of areas of concern. We are rolling out proactive training to the care homes now. We started this at the earliest stages of this year, and things are going very well there. We've given training to over 100 staff across Forth Valley currently, which is really encouraging, and the feedback has been good as well. So we're getting care home managers actually contacting us asking, can we have some additional support because we have new staff and things like that. So that's all very positive to report. For our AOP targets, that's now concluded. It concluded in March of this year. Provisional indications suggest, based on our local data, that we haven't met our targets for our E. coli bacteremias, our Staph aureus bacteremias, or C. difficile infections, unfortunately. Just to give the committee some sort of assurance of some description, that from a national point of view, the targets are not anticipated to be met, and neither is it anticipated that any board in Scotland have reached any of these targets either. I mean, at best, they're forecasting out of the 40, each board's got 3 of these targets, so out of the 45 targets that are possible, it's anticipated there's just 9 targets will be achieved out of the 45 in total across Scotland. So it's not painting a great deal of success in terms of these targets, what being set by Scottish Government. The targets are now since being reviewed. We haven't had any communication from Scottish Government just yet, but we're anticipating that will come in due course. And obviously we'll be reviewing and present, in these reports, the new targets. We don't anticipate any difference in the organisms. It'll continue the same. There'll be just further reductions, I suspect, set for those particular organisms, which I'll be coming on to now. For Staph aureus bacteremias, they remain consistent and low. Therefore, no reported infections from Falkirk Community or Bowness community hospitals, which is good. Device-associated bacteremias, we've had a slight increase this quarter. We do see this seasonally, for whatever reason, maybe due to the acuity of the patients that are coming in the first part of the quarter, certainly in January. But again, no concerns to highlight to you. And also there were no infections reported from Falkirk or Bowness. Our E. coli bacteremias, again, similar to the device-associated bacteremias, slight increases in quarter. Again, this is historical as well, and then we find this for the last 4 or 5 years that we've seen an increase, certainly at the early part stages of the quarter. And again, they're none reported for Bowness or Falkirk hospitals. C. difficile infections, they remain quite consistent. Of those that have been reported, they're all been attributed to antimicrobial therapy rather than nosocomial transmission. So that means, from patient to patient. So which is good, and again, none reported for Falkirk or Bowness. On to outbreaks, there were none reported for Falkirk or community, which kind of takes me on to a bit of COVID. Up until maybe the last 2 or 3 weeks, COVID numbers had reduced quite significantly, across the hospital sites. We're talking single figures. We have seen an increase of late. We don't know whether or not there's a new variant at the moment. The reports that we get from all the whole genome sequencing of COVID isolates are a couple of weeks old, and it doesn't suggest at the moment that the variant that we have is the JN1 variant is any different from the rest of Scotland. It seems to be the dominant strain at the moment, but we are seeing quite an increased number of transmissions ongoing, especially recently, but also new admissions with patients with COVID as well. I'm not entirely sure whether or not subsequent reports from national reports may suggest that there's a new variant being introduced or present at the moment, but as of yet, we're yet to determine the reasons why. We're not alone there. Other boards across Scotland, according to my colleagues as well, have seen increases in outbreaks and increase in numbers of COVIDs as well. Numbers are still manageable. They're nothing as what it was during the pandemic, but it's still about, unfortunately. Influenza rates, they're not. We have the odd patient coming into our hospital settings with influenza at the moment, but nothing to worry about there. So happy to take any questions.
Okay, thank you, Jonathan. Margot, yes.
It's just an observation about COVID numbers, and it's not really your responsibility, but there seems to be a slight problem in patients who are perhaps just through their own lack of understanding. I don't mean people with dementia or anything, but they don't seem to have a kind of feeling of transparency as to why they're being tested and isolated and ultimately discharged. I don't know if there's any evidence of people not being communicated with as to whether they have COVID or not.
I think all patients, certainly within the hospital setting, if they do become positive with COVID, we do some investigations for each case, and my team do support the ward. And when there is an isolated case, that patient is isolated and would be informed of what's going on. The difficulty is with COVID, because it's not unique to the hospital environment, it's actually out in the community, and also we have a lot of patients' relatives coming in as well. It's very difficult to determine the root of that. If there's obvious clusters, if a patient develops COVID in a bay and then subsequently the other people, then obviously we can be fairly assured that that infection resulted from that bay exposure. But it does make it very difficult. We had an instance just the other week where a relative was COVID positive and gave that to the patient, and then that subsequently then spread to the bay, so it is a very difficult one. But to go back to your original point, all patients should be notified of what infections they have. I can ask my team to have a look into that, but certainly that is what our expectations are, that patients should be notified of any infection that they've got.
Thank you, Jonathan. Stephen?
Thanks again, Chair. Jonathan, I'm just interested in the work that you're doing with the care homes, which is commendable. I know that Forth Valley did a fantastic job during COVID. Obviously a challenging environment. You just mentioned COVID with the potential community transmission. I suppose the question I would ask is, if we're finding a difficulty within that care home space in terms of infection control, what's our route for escalation? Do we deal with it, or do we report that to the care inspectorate?
What we do, we have a number of meetings. We have the I've forgotten the title of the meeting that we meet on a monthly basis with health and social care partners as well. And I attend that. That's the meeting chaired by Frances Dodd, the executive nurse director. And if there are any issues that we do actually escalate it in that from to there, we also have a weekly touch base with the care home support team and also other stakeholders on a weekly basis as well. So if there are any concerns, that we do highlight that. I mean, touch wood, we're not seeing that. We have got some care homes that we have present some challenges, but we do work with them on a very close basis just to give them that additional support where required. So there is an escalation process should we need it. As yet, I haven't, because we've managed to sort of deal with any issues. And again, so the issues are not serious enough to escalate, if you like, Stephen. but there is a process. In terms of outbreaks and all that, we don't deal with the outbreaks. That's the health protection team, or the East of Scotland region now, because they've regionalised Forth Valley, and that's now twinned with Lothian, Fife and Borders now. So that team deals with all the outbreaks. So we're just there, just looking at IPC standards, and and that rather than outbreaks like we did during the pandemic.
Okay, thank you. Any other questions or comments? If not, we have considered and commented on the report, and we'll move on to item 10, the annual assurance statement for 23-24. And I think that will be you, Suzanne.
Yes, thank you again, Chair. The report presents the draft Clinical and Care Governance Committee annual assurance statement for approval, and subject to committee's approval today, this will then be presented to the board in September for consideration, and that's as part of a suite of annual assurance statements. The background to requiring annual assurance statements is from a 2019-20 internal audit governance mapping exercise, and that assessed the extent to which IGIB's committee structure supported the delivery of its strategic objectives. And one of 4 recommendations was that annual assurance statements are provided to the IGIB effective from June 2020, and we've been compliant since that time. A draft annual assurance statement has been prepared and is attached for consideration at Appendix 1. It sets out the attendance, meeting dates and business of the committee over the reporting year from April 23 to March 24. Assurance and governance are provided to a large extent by having an oversight and adequate reporting mechanisms from the various health and social care partnership groups, NHS committees and public protection groups within the IGIB governance infrastructure. And these groups can demonstrate in-depth consideration of a broad range of agendas relevant to their specialities. So through the Clinical Governance Committee meetings and reports presented, assurance is provided from respective partners on how services have ensured the safe, efficient delivery of health and care services throughout the year, and how services have been delivered in line with strategic objectives. So in conclusion, committee is asked to approve the Clinical and Care Governance Annual Assurance Statement for 23-24 as set out in Recommendation 2.1, and to agree that this is presented to the IGIB in September for consideration as at the Recon 2.2. I'm happy to take any questions. Thank you.
Thank you very much, Suzanne. Does anyone have any questions or comments? This is a fairly standard report, but we'll also get the opportunity to consider again at the IGB. Okay, thank you very much. We have, I suppose I should ask the question, do we agree that this be presented to the IGB in September? Yes, no one otherwise minded, and we approve the committee's annual assurance statement. Thank you very much. And we'll move on to item 11, Falkirk Mental Health and Wellbeing Planning Group. And I think this is Julia.
It is Councillor Hannah. Yeah, thank you very much for introducing me. Nice to see you all. I'm Julia Frary, Service Manager for Community Mental Health Services, for those that have not met before. So the report you've got in your pack today provides an update for the work around about the Falkirk Mental Health and Wellbeing Planning Group. I'm really grateful to have a bit of time and space to be able to feed some of this activity and information in. I think it's important and interesting for the committee to hear some of this, and our plan going forward is that this information from the planning group sits within the oversight report, so that you're sort of still getting a little bit of information as it goes forward. But I'm certainly happy at any point to come and wax lyrical about the work that happens within here, so more than happy to do that. The group's been in its formation probably for a really long time, probably since about 2015 or pre-2015, but has evolved quite significantly over those years to bring us in a bit more aligned with the objectives of the organisations and bring us up to speed in terms of structure and stuff like that. So it's changed quite significantly. The current group has really good representation from across the partnership, NHS, council, emergency services, our third sector partners, and others that come in and out. And we have a sort of suite of people that we have as sort of distribution for papers, just to make sure that we're reaching as much people across the organisations as possible, and people have opportunity to comment on activity. It provides a supporting role to the partnership, to the Health and Social Care Partnership, and to the Community Planning Partnership in the delivery of the outcomes underneath the theme of mental health and wellbeing within the Falkirk Plan, which are detailed in the paper there. We've got 2 subgroups that we've developed in the last couple of years, probably 2 to 3 years, and I think that came from a point of quite a lot of activity sitting within this group, but feeling a bit like the structure wasn't quite right. So we developed two subgroups within this, which have got a much wider membership within there. And those 2 subgroups are, one is suicide prevention subgroup, and one is a sort of communities mental health and wellbeing subgroup. And as I say, they've got that will include sort of recovery community, Forth Valley College, Bear Scotland. There's lots of different people that sit within those groups to ensure that we've got the best representation that takes us as close to the communities as possible. Those groups meet around about 6 to 8 weekly, and that aligns with our planning group, so that feed-in comes to that group as well. We report every sort of 6 months into the CPP, and in fact some colleagues will, I'm sorry I'm repeating myself because that meeting was yesterday, so you've heard some of this information, so I apologise about that. And sort of last year there was a data set created to sort of have a bit more of a quantitative view of what's kind of happening in terms of activity as a bit of an easy read guide, and that's in your paper today for you to have a look at. So whilst we report into these outcomes, and that's our sort of primary focus, part of the thing about this group is that it's a group of expertise across mental health. So we try to fit into the wider spec around mental health as well. So making sure that we're talking about things like clinical pathways. So we'll get a clinical pathway around about dementia, for example, which not necessarily does that all that activity sit within those outcomes, but it's really important activity, and of course there's a cross check to that. So we've got older adult psychiatry colleagues, joint dementia initiative colleagues that sit on that group and feed in about that dementia pathway working, and actually there's mutual aid in terms of supporting each other around about that work too. So that's a tricky bit, because mental health is everybody's business, and we want it to be right across the system in terms of how we do that, but we've got to kind of try and prioritise and streamline our work a little bit as well. So we do try to do that and streamline activity and make sure that there's a sort of reduced duplication across services, because we're all sometimes serving the same people doing the same thing. So that's really important for us to get together to discuss that stuff. Updates are provided to the CPP on the areas, the 2 groups that I mentioned, but also the community mental health and wellbeing for children and young people, primary care mental health nurses, community link worker programme, our trauma champions, and as I mentioned, the dementia pathway. Looking at the sort of subgroup activity, the suicide prevention group sort of focus around about 6 areas within the local action plan, and that takes in things like people who are bereaved by suicide, workforce development, public awareness and access to wellbeing resources, suicide witness support, and links to the national developments and networks, and supporting the development that's going on in the background around about the Forth Valley Strategic Prevention Plan. And it takes into account things like workforce development and capacity building across programmes that already exist. So things like Scottish Mental Health First Aid, or ASSIST, which is Applied Suicide Intervention Skills Training. So there's still lots and lots of training activity that goes on in the back of this too. Data sharing is also really important as part of that group, and that feeds right through the system coming into planning. The data really helps us, which is proportionately shared in terms of that suicide prevention work, but that's really important to inform our themes and trends and discuss activity and how we support current work and move things forward. There's also the Suicide Prevention Fund, which is funded 5 projects to develop and/or kind of increase capacity of services and support that suicide prevention. That takes into account things like training, development, support and demand within services. Our communities group is the other subgroup I mentioned, which I think is kind of like the engine room of our mental health and wellbeing planning, and really critical to that work. They sort of focus around about 3 areas, which is kind of information and communication, awareness raising, and education and service provision. And a couple of bits of work just to mention on that group that's been really helpful, which has the Falkirk Services Directory is something that some colleagues may have seen. It's a sort of professionals document that's an aid memoir with lots of services across Falkirk. And that's a sort of a document that we've had in some guys for a long time. But the problem with directories is that you need to make sure they're updated, they're current, they're relevant, and there's an accuracy of information. So the communities group take the responsibility for making sure that that's the case, and they annually update that. The other document, and that's in your appendix today, is a sort of help and resources flyer, which is more than happy for anybody to share that anywhere. I keep saying the dream is that we would see it in the hairdressers, or you see it in Tesco when you go in and you see the notice boards. It's a QR code, and really generates that thinking of actually there are lots of services out there for people to access at the right time, and actually we want, you know, again, the dream is that you want people managing their mental health as best as possible, and seeing these things just generates a bit of thinking, oh, there's Samaritans, or there's Breathing Space, I'm going to take that number. So that's a really important piece of work that they do, and they update that work as it goes forward. Decider skills is something that colleagues will have heard, certainly heard me or other colleagues talking about previously, which is the kind of suite of skills around about looking at anxiety and low moods. And we've done lots of activity right across education, health and social care partnership in terms of training people to do that. And there's lots and lots of work around about that. The sort of next piece around about this is how we do community facing decider skills work. We want that to be right out in the communities, you know, again, hoping that we do a bit of work to help the public being able to book themselves on that. Again, that sort of fits into that early intervention and self-management of mental health. And I think that'd be really helpful for the system. So there's a bit of work to be mobilised behind that. I've spoke at this committee about the trauma-informed practice, so I certainly won't go into this in too much detail, but colleagues will know that we've got 3 trauma champions in place, myself and another 2 senior service managers that are in the organisation, and we have a trauma-informed policy officer in place who's mobilising lots of this work, and I'm absolutely sure that most of the people here today will have been part of a briefing or a meeting around about that. For me, one of the important reasons to make sure that it's embedded in these sort of discussions and presentations is that it's got to have that senior buy-in, and we need that embedded in policy for moving forward. So I continue to put it, you know, front and centre so that we don't lose sight of that. There's a couple of, as I said, you've got the appendix in terms of the data there, which is really helpful in seeing the progress from 22-23 into 23-24 in terms of sort of workforce and increase or decrease, but also that activity and what the numbers are kind of looking like. And you've got a sort of group achievements, which is a sort of, you've got the services down the side and our achievements beside that. And we've just tried to sort of map that next to the outcomes, just to try and evidence that, you know, everything crosses over with mental health. You know, one thing doesn't sit, it's not a binary thing. It's usually right across the outcome. So that's quite a nice, easy way of kind of looking at it. So the work continues with this group. I'm actually immensely proud of the work that comes out of this group. We do lots of really good activity. We've got a really good relationship and culture within this structure, and I think it helps massively in terms of us working together to serve people properly. Otherwise you're separate services sitting in different bits of the system, but that real culture of whole system thinking is very much within this collaborative of people, and a real appetite for us to kind of come together. It's always well attended, and there's always a real appetite to sort of put work in there, and I'm absolutely keen to keep that going and improve it as we move forward. But hopefully that gives colleagues a little bit of an insight into what that is like, and I'm more than happy to take any questions or have any either now or after the meeting.
Thank you very much, Julia. I'm really pleased to see this report, because it's very important that we address some of the more preventative activities. So often we're looking at the acute services, we're looking at how to deal with a problem at the end of the line, as opposed to how to try and avoid it. And if we are going to promote the health and well-being of our communities, then preventative services are absolutely fundamental. Also want to say thank you for your enthusiasm about the activities, which comes across even across the Teams channel. That's really very much appreciated, and also I would guess it sort of feeds into some of the successes that you've been able to talk about. So thank you very much for that.
Thank you, Councillor Hannah. Thank you.
David, and then was that you, Michael?
Thanks, Julia. I certainly agree with you. I think there has been a lot of good work going on around mental health provision for Falkirk residents. The poster in your report looks a good poster. I don't know if that is that a proposed or is that a live poster?
Well, that's live, David. That's been in existence for a good couple of years.
Okay, so I suppose the only feedback I would have is under the local support, I would have GP or mental health nurse at the bottom of the list, because I think we want to encourage our residents to look at third sector resources first before they present to GP practices. You know, I think that's the ideal route, if you like, rather than the other way around. Thanks.
No, that's fair comment, David. I'll take that on when we review this every year, actually, this document. So happy to do that. We did have lots of discussion around about that, funnily enough, about whether we even have GP on there. But I still think it's important. Well, the decision was that we do, but I think you're right in terms of where it goes. So I'll take that on board for sure.
Absolutely, I agree. I think GP needs to be on there because we do want to see people with mental health where medication's needed and such like. But there are good resources out there for people to access before we start considering, you know, the treatment that we offer. Thanks.
If you maybe just like to say, Julie, about that, how widely it's distributed, and if there are things, because you're saying you want to see it in every hairdresser, and everything to the hairdressers.
Yeah, so I think I would welcome views about how we do that. Actually, it is out there fairly widely, and we probably do have it in our supermarkets, and we've sent it. We've done sort of shots of this at various times, but I think probably we're not sort of. We've not had a set way of setting it out regularly, you know, and I think probably that's something that we should do. I mean, short of putting them in my car or taking them out myself, which I'm not necessarily against, I have to say. But that you know, however we get that out there, I would welcome. And Jessie and Malcolm, who people will certainly probably know on the call, is really good, a really good contact and conduit in terms of sending things out. So she's really been heavily involved. She sits on that communities group for us as well, and has a great public involvement and access to things like the carer centre and stuff that we don't necessarily have contact with from a sort of statutory point of view. So they're really important contacts. But you know, that's something that we always ask at the planning group is, how are we keeping on top of that, and how are we continuing to send that out? Because it'll go up and then come down. You know, that's what happens, doesn't it, in areas? So it continually needs to be kind of refreshed and put out.
The inside of toilet doors. Always.
Yes, always, yeah.
Margot, you were next, and then Stephen.
Right, it was really on behalf of service users to commend the report. We're at the moment getting a lot of negative media coverage about mental health and waiting times and the neglect of people with problems. And I think this provides more effectively than the hustings a good way forward and a very, very good example of our area doing a great deal.
Thank you for that. I'll feed that back to the group. That's really important information. I really appreciate that.
Okay, thank you. And Stephen?
Thank you. Yeah, good report, and absolutely concur with pushing the whole self-help and prevention. And on that theme, Julia, I don't know if there has been any discussion that you're aware of. It did come up at CLAC's meeting the other day. Obviously, the Stress Brief Intervention Service is going nationally now, so I think a really good service. I think I chair an organisation through in the West that was heavily involved in the pilot of that, and we run the biggest one in Scotland, and I've seen great benefit from it. So just about how we weave that into our resources going forward. Has there been any thoughts on that? Thanks.
Yeah, so I think every board and local authority are sort of mandated to kind of move that forward, and Forth Valley are in a position to be moving forward. There's definitely lots of work going on with that, Stephen, which I think will come to the fore fairly quickly once we've got the meat to the bones. But yes, just as an assurance for the committee, that's absolutely on the agenda. And probably once we get a little bit more traction around about that and a bit more firmed up, it's probably worth feeding that in either as part of the oversight or as always. I'd be happy to come and talk about it when it comes to that.
Okay, thank you. Are there any other comments or questions from anyone? In which case, thank you for the report, and we have commented and considered. And we come to, thank you, Julia. We come to the final item on the agenda, which is the national publications. And I think that would be you, Suzanne.
Yes, thank you. Thank you again, Chair. Are you okay for me to continue? Sorry, I'm getting a wee bit of background noise. Can you hear me okay?
Yeah, I think we've resolved that.
Okay, thank you very much, Chair. So this report provides an overview of 8 national reports relevant to the partnership that have been published since we last gave you an update. The links to the reports are presented in the table at section 4. This committee will know this is a standing agenda item, and it recognises that national publications may need to be considered by the IGIB or its committees, dependent on the nature of the report and the associated recommendations. And of course, committee members can highlight if they think that more detailed consideration of any report is required, and if so, what the appropriate reporting routes could be. So 5 reports have been published by the Scottish Government, and 1 each for the Mental Welfare Commission, Alliance and Coalition of Carers in Scotland, and the Scottish Social Services Council. And the report summarises each of those publications and notes where local work is ongoing. Maybe just to highlight a couple of those reports, in relation to the National Dementia Strategy, the initial 2-year delivery plan. We have an established Falkirk Dementia Strategy Group, which has representation from across social work, health and the third sector, and that group are meeting regularly to identify priorities and areas of improvement. And the report at 4.6 notes some of the achievements of the group to date, and also notes that further work is ongoing to develop a local dementia strategic implementation plan that will both consider local needs as well as the priorities outlined in national documents. We intend to bring forward a draft strategy initially to the Health and Social Care Partnership Senior Leadership Team, and then to a future IGIB meeting, and timescales for the development of that work are yet to be finalised. Importantly, though, the work to develop the dementia strategy will involve engagement with service users and their carers and families, as the voice of lived experience is crucial in the development of a local strategy. And this work will be informed by and links well actually into one of the other publications that we report today, which is the Health and Social Care Planning with People, Community Engagement and Participation Guidance. In terms of as a partnership, we have refreshed our participation and engagement strategy and our communication strategy, and these have been issued with papers today for the board meeting next week for approval. The new strategies very much are providing guidance on developing a best practice and consistent approach to carrying out community engagement activities, and has been developed to be informed by national guidance and national standards in this regard. Jumping back a little bit in the report, this also links actually to the More Than Equal Valuing and Supporting the Expert Contribution of People with Lived Experience report, which is been published by Alliance and Coalition of Carers. Carer and lived experience representatives, as we know, bring a wealth of knowledge, experience and expertise to our work. However, the national report notes experiences of involvement across Scotland have been mixed and makes recommendations for areas for improvement. Locally, we have considered those, and the report presented to committee notes the work that we've delivered to date and have planned across the partnership. And we're currently working with the Carer Centre to develop a training programme that could be delivered on an ongoing basis. And the aim is to establish a more sustainable approach to recruiting and supporting carers and people with lived experience to get involved in partnership activities. So in conclusion, the report lists the national reports that have been issued since the last meeting, and committee is asked to consider and comment on the contents of the report as set out in recommendation 2.1. and happy to take any questions.
Thank you very much, Suzanne, and thank you for this report. It's really very useful to have these linked, because otherwise some of us might miss some of these important documents. Does anyone have any questions or comments? Just say I'm very glad that the Falkirk Council is also looking at its community engagement strategy and working with the Health and Social Care Partnership to try and improve the ways in which we engage with the community. And I think the community engagement question and the involvement of people with lived experience almost are just two different ways of talking about the same thing, because the community has all got lived experience of health services and social care services. Any other comments or questions? Margot?
Just a very quick commendation again on the involvement of service users for the dementia delivery plan. I think this is vital. It will not be easy, considering the range of dementia sufferers and their ability to participate, and the continuous decline of some. But I think it's something that's really worth doing, because it's such a sadly growth area in our community. Thank you.
Yes, I think that is, and we will no doubt see any other report about these issues as time goes forward. If no one else has any questions or comments, I'd like to say thank you very much to everyone for their attendance. Thank you very much for all the reports and presentations. And we will be meeting again after the recess. So if there are any of you that I don't see between now and then, I wish you all a good summer. I hope you have a nice time. Hope you've got lovely holidays planned. Thank you very much indeed. Bye.
Thank you.
Thank you. Bye-bye.